Good afternoon. I'm Reem Ali, Vice President at the Health Policy Institute of Ohio. Thank you for joining us for this fifth and final meeting of the MCH MIECHV Steering Committee. Before we get started, I have just a few housekeeping items to go over. For now, everyone is in listen-only mode. We want this to be an interactive meeting though, so if you have a question, please do type it into the question box. There will also be opportunities for discussion later in the webinar. During the discussion, you can raise your virtual hand and we will unmute you. However, keep in mind that if you have muted yourself, you'll also need to unmute your audio. To participate, please make sure that you have entered your audio PIN. You do need to log into the webinar first before calling in order to get your PIN. Both the agenda, slides, as well as a recording of today's webinar will be posted on the MCH MIECHV Steering Committee page. You can find this by going to hpio.net and clicking on Groups. The slides and agenda have also been uploaded under the Handouts tab in this webinar for you to reference during our discussion. As a reminder, HPIO was contracted by the Ohio Department of Health to facilitate development of the Maternal and Child Health Assessment and the Maternal, Infant, and Early Childhood Home Visiting Assessment, or MIECHV, last year. Both of those documents were submitted to the Department of Health in September of 2019. At the beginning of this year, the Ohio Department of Health contracted with HPIO to reconvene this committee and provide updated data and information for the MIECHV needs assessment. Here you see the role this committee has played during that time. Today we will provide you with preliminary key findings from the updated data and information compiled and analyzed for MIECHV. Here is the agenda for our meeting today. And here are the objectives for today's meeting. We'll share preliminary key findings from the federal fiscal year 2019 home visiting capacity analysis and the home visiting provider survey that was administered to home visiting providers just last month. And we'll also provide updates on the substance use disorder treatment and capacity component of MIECHV. We'll also be getting your feedback on this new data and information. As a reminder, here is the federal submission timeline for the MIECHV needs assessment. The final needs assessment must be submitted to the federal government by October 1st of this year. And with that, I'll hand it over to Diane Gogan-Turner, who is the Chief of the Bureau of Maternal, Child, and Family Health at ODH, to provide more background and context on this work.
Thank you. On behalf of our team, I want to thank you for participating on the steering committee during the last year for the statewide home visiting needs assessment. The needs assessment is funded by the Health Resources and Services Administration, or HRSA, an agency of the U.S. Department of Health and Human Services, through the Maternal, Infant, and Early Childhood Home Visiting Program, known as MIECHV. The needs assessment is intended to be used by ODH and any of the state agencies contributing to the building of a system of home visiting in our state and funding local services. We're coming down the home stretch, and we appreciate the work to date from HPIO and the input that you have provided throughout the process. This is our last meeting with you, but please know that you will get a heads up prior to the public release of the final product, which is due to HRSA in October. I'll turn things over to Becky and look forward to hearing your feedback throughout the discussion.
Thank you, Diane. Good afternoon, everyone, and thanks so much for joining us this afternoon. I am Becky Carroll. I am a health policy analyst at HPIO. As Reem mentioned, we have spent the last few months collecting more recent data from all home visiting providers in the state, and we then reran the capacity analysis. I'll be sharing our preliminary key findings from that updated analysis today. So this may look similar to what we presented to you in the past, but keep in mind that these analyses are based on more recent data. I'll go through the inventory of home visiting programs that will be included in the needs assessment. Then I'll quickly review the counties that were identified as at-risk communities for this assessment. I'll introduce ODH's new home visiting regions, and then briefly describe the data that was provided by the Health Resources and Services Administration, or HRSA, to estimate the number of families in need of home visiting services. Finally, I'll spend most of the time discussing our analysis of the percent of need for home visiting services that is currently met through Ohio's existing programs. As we've mentioned before, there are currently 6 home visiting models operating in Ohio, which were designated as evidence-based through the U.S. Department of Health and Human Services Home Visiting Evidence of Effectiveness, or HOME-V review. These are the models that the MIECHV program considers to be evidence-based. Of course, there are numerous other home visiting programs operating throughout Ohio as well. The ones that will be included in the needs assessment are shown here. One requirement of the MIECHV needs assessment is to identify the state's at-risk communities, which means the counties with the greatest need for home visiting services. For purposes of this needs assessment, HRSA defines an at-risk community as a county or a county equivalent. ODH decided to use a methodology that was developed by HRSA called the simplified method to identify these at-risk counties. HRSA provided the data needed to use this method. It consisted of county-level data on 13 indicators separated into these 5 domains which reflect the need for home visiting. A separate set of counties was found to be at risk in each of these domains. As you've seen before, these are the 27 counties that were determined to be at risk overall for the MIECHV needs assessment. These were the counties that were deemed at risk in at least 2 of the 5 domains that were listed on the previous slide. These 27 counties are really the focus for much of the analysis in the needs assessment. Here are the 6 new home visiting regions that were introduced by the Ohio Department of Health earlier this year and will become effective in July. We broke down some of our analysis by these regions, so I wanted to introduce you to them. One of the primary requirements of the MIECHV needs assessment is to determine the extent to which a state's current early childhood home visiting capacity is meeting the level of need in the state. HRSA provided data to estimate the number of families in need of home visiting services. This slide describes how those estimates were derived. I'm not going to get into the weeds and describe this, but it's here if you're interested. A total of about 84,000 Ohio families were estimated to be in need of home visiting services based off of the calendar year 2017 data that was provided. This map gives you a sense of how those families in need are spread across the state. The highest number in need was found in Cuyahoga County, which was nearly 12,000 families, and the lowest was Harrison County, where the number of families in need was estimated to be 30. Of the 84,000 Ohio families estimated to be in need, we found that about 63% of them live in one of those 27 at-risk counties. HRSA requires states to use these estimates for the analyses that you'll hear about in a minute. However, I did want to point out that the Ohio Department of Health sometimes uses Medicaid-eligible births as the estimate of need. So I want to make sure that everyone knows that we used these HRSA numbers, not Medicaid-eligible births, and that will make some of our estimates of the percent of need met different than what you might have seen before. For the first analysis, we looked at the number of households served through the Ohio Department of Health's Help Me Grow home visiting program, which includes home visiting programs funded through MIECHV. This includes these 3 HomeV evidence-based models: Healthy Families America, Nurse Family Partnership, and Parents as Teachers. ODH also administers the Moms and Babies First program, but that is not going to be included in this analysis. Help Me Grow is Ohio's largest home visiting program, serving families in 86 counties in federal fiscal year 2019. All except Lawrence and Logan counties had at least 1 household served through MIECHV during that year. A total of 8,755 households were served through ODH's HomeV programs in federal fiscal year 2019. This represents 10.4% of the number of Ohio families estimated to be in need of home visiting services. And 84% of those households were served by the Healthy Families America model. This map shows the percent of estimated need met in each county through ODH HomeV programs. Lighter shades of yellow indicate that a lower percentage of the estimated need was met, and darker shades indicate a higher percent of need met. The estimated percent of need met ranged from 0% in Lawrence and Logan counties to 220% in Harrison County. The next highest was Vinton County at 68.2%. 58 of the 88 counties had less than 15% of their estimated need met, and 75 counties had less than 25% of their estimated need met through ODH's HomeV programs. This is a copy of the same map, but it highlights the 27 at-risk counties. No households in Lawrence County were served through an ODH HomeV program in federal fiscal year 2019, so Lawrence County is the at-risk county with the lowest percent of need met at 0%. Vinton County was the at-risk county with the highest percent of need met through ODH HomeV programs at 68.2%. I'll pause here another minute to let you absorb all of this information. This table shows other counties with the highest and lowest percentage of estimated need met. You'll notice that 3 of Ohio's most populated urban counties are among those with the lowest: Summit, Franklin, and Cuyahoga, all of which had between 5 and 7% of estimated need met. Here we have the percent of estimated need met by home visiting region. Region 1 had the highest percent of need met through ODH HomeV programs at 15.2%, while Region 4 had the lowest at 7.1%. Ohio Medicaid also funds some HomeV home visiting. In federal fiscal year 2019, an additional almost 900 households were served through Medicaid-funded HomeV programs. Most of these were through the Nurse Family Partnership model. And I'll add that Medicaid also funds other home visiting programs. This only shows the HomeV models that were funded in federal fiscal year 2019. For the next analysis, we looked at the number of Ohio households served through any HomeV model. So building off the last analysis that I described, we added households served through the Early Head Start home-based option, HIPPY, and Safe Care Augmented, as well as additional households served through Healthy Families America and Parents as Teachers programs funded through the Ohio Children's Trust Fund. This table gives you an idea of the reach of these 6 home V models in Ohio. Healthy Families America is the most widespread, operating in 70 counties in federal fiscal year 2019 and serving more than 7,500 families. The program with the smallest reach was Safe Care Augmented, which currently only operates in Hamilton County and served 90 families in federal fiscal year 2019. There were a total of 14,136 households served through a Home V model, representing 16.8% of the estimated number of Ohio families in need of home visiting services. While it is possible that a family was served by more than one of these programs simultaneously, it's not very likely, so we are assuming this data contains no duplicates. Here are estimates of percent of need met through all Home V models by county. I'm going to highlight some differences between this and the last map that you saw, which included the number served through ODH administered Home V programs only. Quite a few counties in the southeastern and southern central portions of the state are darker in this map, meaning that they have a higher percent of estimated need met. And this seems to be largely because of early Head Start. For example, Lawrence County, which is all the way down at the southern tip of the state, went from 0% of need met through ODH Home V programs to 19.9% of need met through all Home V programs. Athens County is another example. It went from 16.9% to 42.3%. Guernsey County, which is in the eastern portion of the state, but up closer to the middle, went from 15.2% of need met through ODH Home V programs to 93.9% through all Home V programs. However, counties in the far northeastern corner of the state stayed pretty light in color, meaning they still had a pretty low percent of estimated need met when these additional Home V programs were added. For example, Geauga County stayed at just 1% of need met. Stark County had 5.9% of estimated need met through ODH Home V programs and 6.7% through all Home V programs. Again, this is the same map, but with the at-risk counties highlighted. Ross County was the at-risk county with the lowest percent of estimated need met. It did not change from 6.8% when we added in the non-ODH Home V programs. As I mentioned, Guernsey County saw a big increase. It had the highest percent of need met of all at-risk counties in this analysis. There were actually only 6 of the 27 counties that had less than 15% of estimated need met when all Home V programs were included. I'll give you another minute to look at this. I know this is a lot of information to absorb. Here are the other counties with the lowest and highest percentages of estimated need met. Guernsey County was the only top 5 county that is different from the last analysis. The other 4 counties were also in the top 5 in the last analysis that included only ODH Home V programs. Muskingum County was the only county that had not been in the 5 with the lowest percent of need met in the previous analysis. It had 7.5% of need met through ODH Home V programs and only 9% of need met through all Home V programs. And again, Franklin, Summit, and Cuyahoga again fell in the bottom 5. Franklin went from 5.3 to 7.2%. Summit increased from 5.2 to 9.5%, and Cuyahoga went from 6.3% to 11.2%. Here is the percent of need met through all home V models for each home visiting region. Region 2 was the lowest at 11.4%, and Region 6 was the highest at 26.2%. In fact, the percent of need met in Region 6 more than doubled from the last analysis, which only included the ODH home B models, to this analysis, which includes all home B models. Conversely, the percent of need met in Region 1 increased only slightly, from 15.2% in our first analysis to 17.7% in this analysis, which is only a 7% increase. So that tells us that there were not many more households served through Home V programs outside of Help Me Grow. Also interesting to note is that the two regions with the highest percent of need met in this analysis, Regions 3 and 6, had the highest proportions of at-risk counties. In Region 3, 5 of the 11 counties are at risk, as are 11 of the 18 in Region 6. Again, here is the statewide reach of the 6 Home V home visiting models. As a reminder, 16.8% of the estimated number of Ohio families in need of home visiting services were served through one of these models. But it's also important to consider these other home visiting and support programs operating throughout the state. You can see that they serve many other families and sometimes provide additional support to those pregnant women or families with young children who are also served through one of those Home V models. This table shows which of all of these home visiting programs are operating in which of the 27 at-risk counties. We found the highest number of programs operating in Hamilton and Cuyahoga counties, with 8 programs in each. Franklin and Summit both had 7 programs. Again, I know there's a lot of information here, so I'll pause a minute. Okay, well, I'm going to stop there and would be happy to answer any questions that you might have. Again, the slides should be posted under handouts if you want to go and refer back to them. But if you have any questions, please feel free to type them into the question box, and we'll give you a few minutes.
As we're waiting for questions, I just wanted to note to folks that we will have an opportunity to discuss these findings in just a bit as well. We do want to go over some other analysis that's included in MIECHV first, but we would like to get your feedback on what you just heard from Becky. So it looks like we don't have any questions coming into the question box. I think we can, we just got a couple.
Okay, I see a question from Raina Sims. Why is the term certified not in the title for Pathways Community Hub when the model is a certification model? Ms. Raina, we'll definitely include that language. We're sorry for the oversight there.
Then Becky, we have another question from Dr. Gabby. It's, do we see better infant mortality rates or child abuse rates in counties with more home visiting? So Dr. Gabby, that is not something that we have looked at specifically, but we can take a look at that. The infant mortality and child abuse rates was information that was used to identify those counties that were most at risk or most in need of home visiting. But we have not taken a look at the data in that way, and we can certainly do that.
All right, well, and Alana, do we have any hands raised?
We do not. We can move on.
Okay, Well, thank you for your questions. Again, as Reem mentioned, you will have more opportunities. So we're going to transition now to tell you about the home visiting provider online survey that we conducted last month and share some preliminary key findings from that. Alana, can you give me control of the slides again?
You got it, Becky.
Okay, thank you. There we go. As I mentioned, the MIECHV needs assessment requires that states analyze the capacity of existing early childhood home visiting programs. As part of this, states are encouraged to assess community readiness through considering gaps in staffing, community resources and support, and other requirements for implementing evidence-based home visiting services and demonstrating improvements for eligible families. You might recall that ODH had originally planned to host regional meetings to gather this information from home visiting providers, but due to COVID-19, ODH chose to administer an online survey instead, and then we hosted 2 webinars to share the findings and gather additional information from home visiting providers. This survey was called the Ohio Home Visiting Provider Capacity and Readiness Assessment Survey. It was open for about a week and a half at the beginning of April and consisted of 23 questions in these areas. We received a total of 99 survey responses, representing 95 home visiting provider organizations, which was wonderful. We had a total of 81 counties represented by at least one survey respondent. We had very good representation across all county types. Here's a map of Ohio counties by county type. We are also pleased to see a large variety of home visiting models and programs represented, and we are happy to collect a variety of perspectives. So now I'm going to hand it over to Reem, who will discuss some preliminary survey findings.
Thank you, Becky. As Becky said, I'm going to go through the preliminary key findings from the online survey, first focused on the questions related to capacity and staffing. We asked survey respondents about the largest barriers impacting their ability to serve all pregnant women and families eligible for and requesting home visiting services. Here, you see the top 10 responses out of a total of 18 response choices that included responses that may have been added in by survey respondents. The most commonly selected response were challenges related to the retention and initial engagement of families in home visiting. This was followed by a lack of adequate funding, barriers related to eligibility restrictions of specific home visiting models or programs, as well as hiring challenges. We looked at how the top 3 barriers selected varied across county types. More than 3 responses are listed under a county type in the event of ties. Red indicates a response that was unique to a home visiting region. Otherwise, common responses are all highlighted in the same color. There was no barrier that was identified in the top 3 across all county types. However, there were several that showed up in 3 of the 4 county types. Initial engagement of families, as well as challenges with referrals, showed up in the top 3 for all county types except for urban. Notably, 2 of the top challenges identified by urban counties did not show up in the top 3 for any other county type. These were funding and administrative burdens. The only other challenge that was unique to a county type were hiring challenges, which was a top 3 response for Appalachian counties. Just for your reference, this is a map of Ohio counties by county type that you've seen a few times now. Here are the top 3 barriers selected by the different home visiting models and programs. Safe Care Augmented, HIPPY, and the Healthy Start programs are not displayed here due to lower response numbers. There was no barrier that appeared in the top 3 for all 7 of the models and programs that you see here. Retention as a challenge appeared in 5 of the 7 programs, all except Early Head Start and Pathways Community Hubs. Inadequate funding appeared in 4 of the 7. And then lots of the same challenges popped up among the Home V models, which is the table that is on your left. Barriers related to retention appeared in all Home V models except Early Head Start. Inadequate funding was a top response for Healthy Families America and Nurse Family Partnership, while initial engagement and challenges related to referrals appeared in the top 3 for both Parents as Teachers and Early Head Start. The only top 3 challenge that was unique to a Home V model were hiring challenges, and those were selected by Nurse Family Partnership programs. Now, there was not quite as much consistency among the top 3 challenges identified by the other home visiting programs, which is your figure to the right. And there were more that were unique to a single program. For example, Moms and Babies First programs identified Ohio Department of Health eligibility restrictions and staff turnover and retention as top 3 challenges. The hubs called out data reporting and hiring challenges, and Spark programs identified initial engagement with families as their top challenge. Home visiting respondents were also asked how often their home visiting program had a wait list. About half of programs reported never or rarely having a wait list. 21% said sometimes, and nearly 30% said either very often or always. We looked at waitlist responses, again, across home visiting models and programs. Similar to the other slide, HIPPY, Safe Care Augmented, and Healthy Start are not shown here due to smaller response numbers. The model with the highest percentage of programs reporting that they very often or always had a wait list was the Nurse Family Partnership. And on the flip side of that, you'll see that none of our respondents representing Moms and Babies First or the Certified Pathways Community Hubs reported very often or always having a wait list. Survey respondents were also asked if they had trouble finding and hiring qualified staff for home visiting positions. About 27% of programs said they usually or always, those gray slices, have trouble, and another 40% said that they have trouble sometimes. Just pause here, give you a second to digest this information. Of those who usually, always, or sometimes had trouble finding and hiring staff for home visiting positions, by far the 2 most common reasons identified were compensation is too low to attract desirable candidates, and candidates lacked required experience or degree. This was followed by candidates lacking the necessary knowledge and skills. The figure that you see here looks at the top reasons for hiring challenges by home visiting regions, and you'll note that those are similar to what I just described for the state overall. there is also quite a bit of consistency across home visiting regions. The Oli region that had a response that was unique to that region was Region 5, and barriers associated with training made it into the top 3. All right, I'm gonna pause here just to see if anyone has questions before moving to the preliminary findings related to community resources, supports, and recommendations for improving home visiting in the state. Please remember that you are welcome to type your question into the question box.
Reem, we do have a question from Anita Armstrong. Can you please describe what is meant by initial engagement as a barrier?
Thanks, Anita, for that question. So it did vary a little bit, but what respondents were describing was that it was they were finding difficulty in the initial I guess onboarding of a home visiting family, even getting them engaged in wanting to be a part of their home visiting model. So they may have identified an eligible candidate, but then actually getting them to um, receive services or get engaged in the system was a challenge. Any other questions before I move on? And of course, you'll have the opportunity once I finish reviewing these findings to ask additional questions.
We have a question from Dr. Gabby. She says, why are there restrictions of eligibility for moms and babies first? Dr. Gabby, I'm not quite sure I'm following your question. If you want to put a little bit more detail in the question box, we'd appreciate it. Reem, do you have anything that you want to say on that one?
Well, I think, Dr. Gabby, you might be referring to the restrictions of eligibility that was noted as a barrier for Moms and Babies First programs. And so that is something that respondents, so home visiting providers, have noted that they're finding a challenge, that there are restrictions with eligibility through ODH. We don't have more information to go off of. It's something that they noted. So we can take it back to ODH to see if they have additional thoughts on what that means or what that reflects.
Great. And Reem, it looks like Dr. Gabby says yes. So I think you interpreted it correctly.
Okay. All right.
Okay. We have no other questions at this time.
All right. I'll go ahead and move on. Yep. We also asked respondents whether there were adequate health and social services and family supports available and accessible to pregnant women and families with young children who were in need of those services, to gauge whether there were adequate community resources and supports within their communities. Nearly half of respondents said yes, while the other half responded somewhat or no. We asked those who responded somewhat or no to identify where the most notable gaps in services and supports were. Here you see the top 10 responses overall. You'll note that 50% or more of respondents identified that the most notable gaps were around childcare, housing assistance, and diaper banks. Notably, both parental and pediatric mental health treatment and services and supports were among the top 5 responses. We also took a look at top 3 responses to this question by the 6 home visiting regions. More than 3 responses are listed under a region in the event of ties, and again, red indicates a response that is unique to a home visiting region. Similarly to the state overall, Housing assistance, child care, and diaper banks were the most common response across the regions. They were identified in 4 or more of these 6 regions. Pediatric primary care and specialty care services were identified as a unique top 3 gap in Region 1. Utilities assistance and car seats were identified as unique top 3 gaps in Region 3. And additional baby supply assistance was a unique top 3 gap in Region 5. I'll give you a second to look at this. In the survey, we also asked questions to identify the extent of collaboration among home visiting programs and between home visiting programs and early childhood education programs. Here you see responses describing the extent of collaboration among home visiting programs in a county. Notably, about a quarter of respondents indicated that home visiting programs in their county made or shared referrals and or provided transition support to one another, and that there was strong collaboration or coordination in their county. Other top responses included having regular communication or meetings and sharing services, trainings, resources, and or space. Nearly 15% of respondents did indicate that there was a lack of collaboration and coordination in their county. Top responses by home visiting region were very similar. However, competitiveness was identified as a top 3 response in home visiting region 3, which is in the southwest part of the state, as well as in region 4, which is in the northeast part of the state. Here, you see responses describing the extent of collaboration among home visiting programs and other early childhood education programs in a county. Again, making or sharing referrals and transition support were top responses. Nearly 30% of respondents indicated strong collaboration in their county, while nearly 20% indicated a lack of collaboration. Collaboration in the form of participation in a joint committee, council, or other initiative, and sharing services were among top 5 responses. There were no notable differences in top responses by home visiting region. Survey respondents were also asked to assess whether there is an understanding and appreciation of home visiting in their county. More than 86% of respondents said there was either some or widespread understanding and appreciation of home visiting. Nearly 14% said there was very little understanding and appreciation. Of those who said there was very little understanding and appreciation of home visiting within their county, confusion and lack of understanding about what home visiting is were the primary reasons cited for why it appeared like there was not buy-in or support. And you can see those top responses listed in the gray bars. I'll give you a second to look that over. Survey participants were also asked how state agencies could work more effectively and efficiently together to support home visiting in the state. Top responses included promoting common goals between home visiting programs and partners, increasing automatic referrals to home visiting from Child Protective Services, WIC, and Medicaid, increasing public education and awareness of home visiting, increased funding support, promoting a unified home visiting approach, including common definitions of home visiting, as well as increasing coordination of state-level meetings and communication across state agency and local level partners. I'll give you just a few seconds to absorb and reflect on this slide. As many of you, all of you really know, the governor convened an advisory committee on home visitation early last year and charged the committee with developing recommendations for achieving his goal of tripling the number of Ohio families served through evidence-based home visiting. The report included 20 recommendations to expand and enhance the quality of home visiting services in Ohio. We asked survey respondents to identify which of the governor's recommendations were most important and should be prioritized. And here you see those top 10 responses. Top responses included expanding and streamlining eligibility requirements to increase the number of at-risk families that could be served, as well as improving the way children involved with child welfare are connected to home visiting services, and ensuring provider payments and reimbursement rates are adequate, tied to the skill level of the home visitor, that there's funding for supervision, and it enables providers to expand their programs. All right. So we have just reviewed a lot of information, and again, want to give you a chance to ask a question. If you have any questions either on what Becky presented earlier or on these online survey findings from home visiting providers before we move on to the discussion. You are welcome to type your questions into the question box. You can also raise your virtual hand and we will unmute you. If you've muted yourself, you will have to unmute yourself in order to speak. So I'll just pause for a little bit to see if we have any questions before we move into our discussion.
Reem, I am not seeing any questions.
All right. Well, let's go ahead and move to the discussion questions. So we have 3 questions we'd like to get your feedback on this afternoon. And we can start with the first 2. And the first is, what did you find most notable about these findings, both the survey findings as well as the capacity analysis findings that Becky shared with all of you? And if there was anything that you felt was not captured in either the capacity analysis or survey findings that you feel is important to highlight or consider, please let us know what that is so we can take it into consideration and reflect that in the MIECHV needs assessment. You are welcome to type any comments that you might have into the question box or raise your virtual hand. I'd love to hear other voices, other non-HPIO voices. So please feel free to raise your virtual hand and we'll unmute you so you can give your feedback. As we're thinking about what to highlight in the MIECHV needs assessment, it would be really helpful to know what really struck you, what you found to be most notable, something that you maybe didn't know that you learned through this analysis or that you found particularly interesting or intriguing. I think we do have a hand. Is that right, Alana?
We do. Dr. Gabby, you're welcome to speak.
Okay, thank you. Well, first of all, I'm glad you included all the home visiting programs in this analysis. I wonder why the federal Healthy Start programs are not considered to be evidence-based. And my second question is, now that you've included all the home visiting programs, are we meeting the governor's initial goals for increasing home visiting? And that's about all I have right now. Thank you.
Thanks, Dr. Gabby. Becky, do you want to take the federal Healthy Start?
Sure. Yes. So The federal Healthy Start sites, I know, there is a requirement for them to use an evidence-based model or curriculum, I believe. But for this analysis, we were only using the models considered evidence-based through the Department of Health and Human Services Evidence of Effectiveness Review. So it's a specific review that's done by the MIECHV program. So those are the programs that are considered evidence-based by MIECHV. So that is why we only have those designated as evidence-based. We know that there are other programs operating in Ohio with evidence of effectiveness, but that is the distinction. Reem, do you want to add anything to that to make sure it's clear?
No, I think that covered it. And then Dr. Gabby, to your other point about whether we met the governor's wanting to triple the number of home visiting programs, that's not something that we're able to answer, but I think it's certainly something that ODH and is looking into to see what that means for Ohioans and the recommendations that were laid out by that advisory committee. We do have a few comments, so I'm going to go ahead and read those. This is from Raina, and Ms. Raina said, what's most notable is there is still a need even with all of the home visiting programs. So there should be no competition, just a point to make sure families are served by culturally competent, accessible, and holistic programs that best meet their needs. Thank you, Ms. Raina. Yes, so certainly there is still quite a bit of unmet need in the state, even when considering all of the home V programs, and even with the understanding that there are additional home visiting programs that are either providing new services or supplemental services to those that are receiving services from home V models. And so there certainly still is quite a bit of unmet need in our state. We have another comment from Suzanne Prescott. While the percentage of coverage for counties is helpful, the numbers are also important to see how many children are not covered in the larger counties. Is there a reason that was not also included? So how many? Suzanne, if you're able to speak and just elaborate a little bit on your question, that would be great, just to make sure that we are understanding it fully. I'm going to move on to our next comment, and hopefully, Suzanne, you're able to unmute yourself so that you can elaborate a little bit more on that question.
Reem, I can take a stab at responding.
Go ahead, Becky.
Okay, I think what Suzanne is saying is, while it's helpful to see the percentage of coverage, the actual numbers are important to see how many children are there in a county that are not being served. Suzanne, we do have that analysis and will include the actual numbers served in the final needs assessment, but percentages were just an easier way to present the information. As you know, we already presented a lot of information, so we figured it would just be easier to absorb. Reem, do you have anything to add there? If that
No,
is
and
indeed
I
what
think that is what Suzanne was asking about. She said, "I'm just asking about the raw numbers." So yes, those numbers will be included in the assessment because we do have that. We have the HRSA estimates of families in need by county, and so we will include that information in the assessment. But just for the webinar this afternoon, it was easier to share with percentages to give a feel for what it looks like across the state. I think we have one more comment from Tara. It's how will this analysis inform the development of strategies to reach more eligible families? I think that Alicia Leatherman, who oversees the home visiting program at ODH, has indicated several times that this analysis is really intended to help inform the provision of home visiting services across the state and is not just restricted to Help Me Grow programs or MIECHV programs. And so our understanding is that ODH will be using the MIECHV needs assessment to help inform their efforts and work across the state in conjunction with other state agencies and partners. Diane or Becky, anything you'd like to add to that?
Nope, that's correct. Thank you.
All right. Any other comments?
I do not see any comments or questions right now. So as
Okay,
long as we don't have any other hands raised, I think we can go ahead and move on.
Okay, we can move on to maybe the last question that you see here. Oh, I'll just go back one slide, which is what recommendations do you have for how the state can address the challenges that were identified? And we're talking specifically about the challenges that were identified by the home visiting providers. So if you have any thoughts or comments on that, please share.
Reem,
I
we
see
did.
a few.
Yes, go ahead.
All right. So Ms. Reina, you said it will be important to look at the racial and ethnic breakdown of data in the regions to further show disparate need. Thank you. Thank you for that comment. Anita, you find it notable that there is room for improved collaboration and reduced competition in order to meet the needs of more families. A recommendation is bringing the various groups together to improve working relationships. Thank you so much, Anita, for that comment and feedback. Also, another comment around including disaggregated data. Great, thank you. Any other thoughts or comments? Or any recommendations given the analysis or findings that you have seen this afternoon? All right, I'm not seeing anything. Becky or Alana, are you seeing any?
I am not.
Okay.
We're all good on my end too.
All right, well, I think we can move on to the SUD portion of the MIECHV needs assessment. Oh, just one more comment before we move on. Mental health services and supports, ranking right after childcare, housing, diapers, I think highlights additional need for support for quality mental health programming for parents. Yes, that is definitely a response that came up quite a few times in the online survey, that there is an additional need for parental support around mental health. And we'll actually dig a little bit into this in the next presentation from our colleague, Amy Bush-Stevens. So I will hand it over to her.
Good afternoon, everyone. We're going to change gears a little bit to another component of this project. And Reem and Becky have just shared a lot of really valuable information with everyone. So if you want to take a brief moment to kind of pause and stretch, that would be fine. And again, as I go along here in my part of the presentation, please feel free to jump in with questions in the question box, and then we'll have some time at the end for discussion. In July of 2019, we prepared a draft report for ODH and shared the preliminary findings with this steering committee. So this information should sound somewhat familiar. We got your feedback at that meeting in the summer, incorporated that into the final version of the report that we submitted to ODH in August. And for this current phase of the project, we'll be updating a few of the data sources. Today, I'm going to talk about components of the project briefly, go through the key findings, share the opportunities for improvement, and then we'll have a discussion to hear your thoughts on developing a more strategic approach to addressing these challenges. These are the sections of the report, and the purpose was to describe substance use disorder treatment capacity for pregnant women and for families with young children who may be eligible for MIECHV services. Unfortunately, it's difficult to get timely, valid, and reliable data on the capacity of the behavioral health system, and there's limited data on prevalence, system capacity, and effectiveness of current services and programs. This report pulls together data and information that we do have on pregnant women and families struggling with addiction, but there's still gaps in what we know, and we relied on key informant interviews to help fill in some of those gaps. Here are the key strengths that we identified when we looked across all of this information. The first is that we have many policies designed to increase access. Ohio has implemented several policies that are aimed at improving addiction treatment access for low-income pregnant women with substance use disorder. For example, Medicaid eligibility levels are designed to increase access to care for pregnant women, and pregnant women are identified as a priority population for publicly funded community behavioral health providers. We also know that the Department of Medicaid has continued to improve and expand access for this population. There's the new Mom and Baby Dyad program, as well as ODM is pursuing from CMS the ability to extend eligibility to 12 months to families after delivery. Second point here is about programs for families. The Ohio Attorney General's Office, the Department of Mental Health and Addiction Services have both led development of 3 major programs that serve the MIECHV population for parents struggling with addiction. So this is the Ohio START program, the MOMS program, and the SAPT Women's Set Aside program, and these have all reached hundreds of families. We've also seen improvements to treatment capacity. Some of the key informants that we talked to said that they feel that there really have been improvements in treatment capacity in recent years, particularly related to medication-assisted treatment, MAT, and outpatient care. This map looks at the 3 major programs that serve the MIECHV population with SUD, and we did share this map before, so it should look somewhat familiar. All right. And just something to note in this map is that we do still have gaps in access to these types of programs. Only 6 counties have all 3, and 53 counties lack all 3 of these programs. So those are the gray counties. Moving on to more gaps and barriers. The first thing to point out here is that while opioids are certainly important, we also need to be focused on marijuana, alcohol, tobacco, and other drugs. Alcohol and tobacco use during pregnancy are particularly large challenges for Ohio compared to other states. We have seen troubling trends upward over the past several years in neonatal abstinence syndrome and the number of women with drug abuse or dependence at diagnoses at the time of delivery. But I will say in the 2 most recent years that we have data for, 2017 and 2018, the NAS trend has come down a little bit. And then child welfare, parental drug use, as we all know, is a major source of children entering the child protection system. Here's trend data to illustrate some of these challenges. The first thing that jumps out is that top line, which is marijuana. This is the most common substance reported here. This is based on hospital reports of women diagnosed with drug dependence at the time of delivery. And the second thing to note here is the general upward trend. Additional gaps and barriers that we highlight here are gaps in wraparound services and recovery supports. So these are things like childcare provided during treatment, transportation, employment assistance, and particularly housing. There's limited program reach and reliance on federal grants. So while the Ohio Start Moms programs and SAPT Women's Set Aside programs have reached hundreds of families, we saw those gaps on that map. There are still 53 counties that don't have these programs. Gaps in treatment capacity. Key informants cautioned that while Ohio has built treatment capacity in recent years, there's still many unmet needs, particularly considering MAT is not effective for non-opioid SUD. That's a challenge, and also lack of residential treatment. And fragmented care. Here we heard a lot from the key informants about the complexity in the healthcare system and how that makes it difficult for families to navigate and to get the help that they need. Here are just a few quotes from the key informants to illustrate what we heard. The first is about the challenge of housing, and the second about treatment capacity. Give you a minute to look at those. Okay, then lack of data is something that we highlight in the report, and I've already mentioned that. And then finally, lack of connections between addiction treatment providers and home visiting programs. So there doesn't seem to be, at this point, strong collaboration between community SUD treatment providers and the Help Me Grow home visiting program. Key informants from the treatment side, treatment and recovery perspective, were not very familiar with home visiting, and so there appears to be many opportunities to strengthen collaboration between OMAS and ODH to help drive more collaboration at the local level. In the report, we conclude with several opportunities for improvement. And I did share these. We did take a look at these back in the summer. So I'll just briefly highlight those. The first is to improve our data. So really improve data collection, data sharing, and evaluation, so we know what's effective and what's needed. The second is to lead a comprehensive approach, including all types of substances and different treatment modalities. Third is to extend the reach of the existing programs that we have, so making sure that all families who need Ohio Start, the MOMS program, and other services have access to them. And then expanding wraparound services with a focus on recovery housing for families. And finally, strengthening those partnerships between substance use disorder treatment providers, children's services, and home visiting programs. And now we would love to hear from all of you, either by raising your hand or typing into the question box. I've got 3 discussion questions for you, starting with these 2. Which of the opportunities for improvement need the most urgent action and why? And I will just quickly review those again. So these were the opportunities for improvement, and we would love to hear your feedback on which of these you feel is the most urgent. Why does it need our urgent attention? Obviously, all of these things are important, but it would be great to get a sense from this group on which ones are most important, or if you have any additional kind of context to add for those opportunities. Okay, we have a comment from Raina. Data collection is the most urgent so that we can further refine the services needed. Thank you. Other thoughts on those opportunities?
Just as a reminder, the slides are a handout. If you haven't already pulled them up, if you want to refer back to that slide, you can do that. And then Amy, I don't know if you're able to just go back to the slide with opportunities for folks to see.
Yep.
Great.
So we've got data, a comprehensive approach, extending the reach of our current programs, expanding wraparound, and strengthening partnerships. Okay, we have a comment here from Jody Demohudgens. We need to improve communication and connections between mental health and substance use disorder providers and our current programs. So current, and I assume that means current home visiting programs. Okay. And then from Dr. Gabby, housing for pregnant women should be a priority. Home visiting is difficult when there is housing insecurity. Make sure it's comprehensive. All right. Thank you for that input. Okay, I'm going to move us on to the second question, which is which state entity or entities should be charged with leading a strategic approach to act on these opportunities for improvement? And just as a point of reference, here are some of the state level entities that play a role in this work. And the question again is which of these entities should be charged with leading a strategic approach to act on these opportunities for improvement? See a comment here from Anita Armstrong. Building effective partnerships collaboration is both important and urgent in order to maximize available programs and reach families in need of services. Thank you. From Jody, OMAS, ODJFS, ODM, ODH, and OCTF. Okay, so five specific entities. From Dr. Gabby, the Governor's Office of Children's Initiatives. Okay, from Suzanne, it seems like the Governor's Office of Children's Initiatives makes the most sense to lead since there are so many state agencies involved, although ODH seems to have the most experience and longevity. Okay, thank you, Suzanne. Any other thoughts on agencies? Okay. All right, and you feel free to continue to respond to those first two questions, but I'm going to move us on to the last question here, which is what systems or policy changes would support a strategic approach? And then we have from Tanya Fullwider, one agency may lead, but it will need to be a collaborative process. So regardless of whichever agency is the lead, making sure that all of those partners are involved. Okay. So thinking about those big picture system changes or policy changes to support things like better data collection, better attention to housing, stronger collaboration. Any ideas on that? And of course, feel free to raise your hand. I don't think we have any hands raised. Oh, did I miss a question in the question box possibly? Let's see. I think I got them all. If I missed anyone's comments in the question box, I apologize.
Amy, I think I see the one that was missed. It was from
Okay.
Jody. She says, I'm wondering if we also need to improve knowledge about SUD and mental health by home visiting providers.
Okay, so some of that education across sectors. Okay, thank you for that. I see another comment here from Dr. Gabby, pooling funds from each stakeholder into a common fund to focus on the high-risk counties with the most at-risk children and build a comprehensive approach. Okay, and then from Anita, we have the suggestion of OCTF and FCFC, Ohio Children's Trust Fund and Family and Children First Council. All right. Well, I don't think we have any hands raised.
Correct, we're all good.
Okay. All right. Well, thank you everyone for your comments and feedback, and we are able to save a log of all of these comments, and that will be really helpful as we're pulling together the final document for ODH. And I'm gonna cede my control back to Reem.
Thanks, Amy. And thank you all again for your feedback and participation during this webinar. In terms of next steps, as previously mentioned, the MIECHV Needs Assessment update is due to the federal government in October, and we will have our update submitted to the Ohio Department of Health in June. The Department of Health will be posting the final needs assessment once it has been submitted to the federal government. We just want to thank you again for your participation. It has been instrumental in helping to develop a strong needs assessment for Ohio's home visiting programs. And we know that it has been a long engagement in this process over the past year. So we do appreciate that and all of the feedback you have provided along the way. We hope that you all are staying healthy and that you have a nice rest of your afternoon.